finish that, and then we'll start putting things in motion. Okay, remember I said last time that the air tubes that go into the lungs, the bronchioles, or the bronchi and bronchioles, are like an upside down tree, right? So here's just looking at that as kind of a framework, all right? So here's the trachea coming down from the larynx. Here's the carina, right, where the left and right split. And then we have a left primary bronchus and a right primary bronchus that go to the left and right lungs. Okay. The next big branches are secondary bronchi. They go to the lobes. Okay. And then from there, we have tertiary bronchi, or bronchus is plural, or is singular, bronchi is plural. Okay, so we have tertiary bronchi. Then we get down, and these tubes are getting smaller and smaller. So just like in the vascular system, where large vessels divide into smaller vessels, those vessels then divide into smaller vessels yet. We have that same pattern here. Okay, so tertiary bronchus, eventually we get down to what are called the terminal bronchioles. Bronchioles have lost their cartilage plates, okay? Just like if you look at a tree, the stems of the leaves don't have bark, right? It's the same kind of thing. You know, the bark disappears as we get smaller and smaller. The bronchioles give way to what are called terminal bronchioles. That just means the last bronchioles, or the end bronchioles, okay? They divide to form respiratory bronchioles, better picture in a minute. And then at the end of this tree are, of course, the leaves. And in this case, the leaves are the alveoli of the lungs, which are the functional unit. That's where oxygen and carbon dioxide actually move in a meaningful way, all right? So last time, or the time before, I said we divide the respiratory system into upper respiratory tract and lower respiratory tract, right? That's the most common clinical definition. When you get into pulmonology, or the study of the lungs as a specialty, they will divide it into the conducting portion and the respiratory portion. What they mean by that is the conducting portion are all of the airways that move air but don't participate in oxygen and carbon dioxide exchange in the body. The reason for that is the walls are too thick. So until you get all the way down here to the respiratory bronchioles, there's too much distance between the air inside the tube and the tissues of the body for oxygen and carbon dioxide to actually move. In order for those gases to exchange, you need to have a very thin membrane in order to make that happen. So essentially, everything from the respiratory bronchioles on up is all conducting portion. And then from the respiratory bronchioles on down is respiratory portion. We use the word conducting because all these structures do is conduct air from one place to another. Okay, so we call them the conducting airways. Okay. So then we zoom way in. Can you hit those lights for me, the front ones? Just so that it's a little easier to see. Thank you. So now we've zoomed way in to this region right here. Okay, so the box has been expanded. So of course everything gets bigger. All right, so we have a branch of the pulmonary artery. The branches of the pulmonary artery follow the air tubes down into the lungs. So they follow the bronchial tree, is what we call that set of tubes. So this is blood coming from the heart, and it's blue, right? So it's deoxygenated because it's going to get down here into the alveoli and actually pick up oxygen. Traveling with that branch of the pulmonary artery, here's a bronchiole. So you see it looks very different than its big brothers do, where we have these cartilage plates and kind of a rigid, tough tube. In the bronchioles, really it looks more like a vessel than an air tube. Okay, so we have air is in here, right? And we have smooth muscle wrapped around these bronchioles. The smooth muscle is there to control the bronchiole size. Okay, so the bronchioles are the principal source of resistance in our respiratory system. In other words, the effort it takes to breathe air out or pull air in is pretty much determined at this layer, or at this level, at the bronchioles. So the fact that these tubes can change size means that the respiratory system's resistance can either go up or go down. So, I'll give you an example. When you go from rest to exercise, in the normal case, these bronchioles dilate. They get a little bigger. That allows air to flow more easily down into the respiratory or gas exchange portions of the lung, right? We're going to get to this in a minute, so ignore my partial pressure stuff right now. All right. Okay, so they change size. This is also the principal site, I think I mentioned this last time, where asthma affects patients. Because these bronchioles can get bigger or smaller, it means they can respond to stuff. And in asthma, the problem is these bronchioles respond inappropriately to substances in the air or even in the blood coming in through the digestive tract. So the short version is these bronchioles can change size. Why not just have them be one size all the time? Because when we're at rest, for example, we want to keep our moisture in, so we're not losing water all the time. So when we're at rest, our bronchioles are kind of small and resistive, so that air has a harder time getting out, and the moisture that goes with it then has a harder time getting out too. All right, so bronchioles, they divide and get even smaller, and they start to get these little sphere-like structures sticking off the sides of them. So if you imagine that there's a tube behind this that looks a lot like this, that's a respiratory bronchiole. So it's a very thin tube, and it has these little rooms or these little spheres that are hanging off the edges of it. Now eventually this respiratory bronchiole, which is like the stem of a leaf, it comes down here and it expands out to form this complex structure of alveoli. Now, alveoli has the same root as grape does. So if you look at this, you can kind of imagine a bundle of grapes, right? They all have a common stem, and you have all these spheres hanging off. Well, that's pretty much what the alveoli look like geometrically. Okay, so here one has been cut open, so you can see that essentially this is an air space inside, and wrapped around all of these spheres of air are blood vessels. That's what they're showing you here. There's a little bit of smooth muscle, but this is pretty much what it looks like across here. They've just taken it out so you can see. Okay, so surrounding all of these alveoli are rich capillary beds. All right, and the short version is, as the blood goes from the pulmonary artery down here, it crosses these capillary beds. Inside this sphere is air, okay? So as the blood crosses this very thin-walled air sac, oxygen diffuses into the blood, carbon dioxide diffuses out. So it's at the alveoli where the work of the respiratory system is done. Okay, so we call this the functional unit. So the functional unit of an organ is where the work of that organ finally gets done for the body. Why do we have lungs? We have lungs to bring oxygen in and carbon dioxide out. And that happens here at the alveoli. Through the combination of air in these tubes, or in these spheres, and the blood coursing along the outside of these thin-walled sacs, allowing oxygen and carbon dioxide to change places. All right, so we have the sort of microanatomy of the lungs. Now, the oxygenated blood is going to go out another way. So instead of the oxygenated blood going along with the pulmonary artery, it takes a different path out of the lungs. So it goes out through branches of the pulmonary vein and eventually back to the heart. All right, so key anatomy here, the respiratory bronchiole, which is behind here. Alveolus is plural, alveolus is singular, alveoli is plural, okay? An alveolar sac is this sort of open space where there are lots of alveoli that open into it. You see how this is a big old space right here, and it has little rooms off to the side, so little alveoli off to the side. And then the alveolar duct is where air enters the alveolus here from the respiratory bronchiole. And we're going to talk about the pleural cavity later on, so ignore that for now. Yes?
I'm sorry, I'm a little bit confused by the picture. Is 5 where it says alveolus, are those two like little
These
round
guys.
sacs?
Yeah, an alveolus is just a spherical sac.
So those are not the same as the alveoli in the bottom?
No, they're the same.
They are.
These are all alveoli. This is an alveolus. Yes, all the little ball-shaped things are alveoli.
And they're all connected to this alveolar
They're all
sac
connected to that respiratory bronchiole or to each other.
through the alveolar sac.
The alveoli that are connected to each other are connect at that sac right here, and some of the alveoli are connected right to the respiratory bronchiole.
Oh.
You kind of see that?
Yes.
Okay.
Okay.
All right.
Thank you.
Sure. Others? Zooming in again, now let's look at the alveoli themselves. Okay, so remember, this is the business end of the respiratory system. This is where the work gets done. And it is evolved for that work. Okay, so the work is we want oxygen to get into the blood, and we want carbon dioxide to get out. In order to make that happen, we have to take blood and put it very, very, very close to air in order to have diffusion move the two gases across the cell membranes. So thinness is the key here. So in here, this is all air, okay, and the cross-sectional pieces, this is where you really see what's happening. All right, so these flat cells, squamous epithelial cells from last semester, right, are very broad, but very, very thin. You see how thin these guys are? Much, much thinner than a red blood cell is across. So some of the thinnest cells in the body are these guys right here. So these flat, broad cells, we call them type 1 pneumocytes, okay, because they make up most of the respiratory tissue. And their job is really to be thin, okay? So there's just a thin barrier between air and blood. Next to these type 1 pneumocytes, like right here, this is a capillary. Okay, so capillary wall cells are also very, very thin. They're squamous epithelial cells as well. So like at this spot right here, between blood in here and air in here, there's two very thin cells and a membrane in between. So that isn't much, right? That's not much separating blood from air. But because this is such a thin membrane, it means that oxygen can travel into the blood and carbon dioxide can travel out because it doesn't have very far to go. Okay, more on that later. What are these other players here? Okay, so some of the cells that are part of the alveolus look different. They look kind of fuzzy or furry. These are type 2 pneumocytes, so there's a few in each alveolus. And the type 2 pneumocytes have one job, and that is to produce a substance that's called surfactant. Surfactant is a fancy word for soap or detergent, right? So when you put the Dawn dish soap into the pots and pans to clean them up, you're putting in surfactant. What surfactant does is it reduces the surface tension of water. Okay, you all have a strong science background, so you've heard this concept before. You know, water molecules are sticky to each other. And what that means is if you try to make a very, very small bubble in pure water, you can't. Because the water molecules are so sticky that every time you put air in there, the water clings back together and pushes the air out, right? So there's a limit to how small a pure water bubble can be. So what happens when you add soap to water? Well, you get bubbles, right? It's because the soap lowers the surface tension, and it means that air can form microscopic or even macroscopic bubbles in water. You might say, well, why does that matter? Essentially, an alveolus is a tiny little bubble of air in water, because most of the body's tissues are water. So in order to have that be possible, to have there be these tiny little microscopic bubbles in the lungs, we need some soap to lower that surface tension and make that happen. So these type 2 pneumocytes, they create a thin layer of soap that coats the inside of all of these alveoli, allowing them to stay open and allowing them to get bigger and smaller as we breathe in and out. Okay, so in the normal healthy patient, you never have to think about this surfactant. It's always there. It works just fine. It's a very simple physics-based system. When there is no surfactant, though, it is very difficult for the lungs to stay inflated. And it's very difficult to inflate the lungs in the first place. So in a drowning, for example, where somebody has had a ton of water in their lungs, that water washes out the surfactant, and it makes it very, very difficult to open the lungs of those patients. So you have to use high pressure to open those lungs. We also see surfactant come up in preterm babies. The lungs are one of the last organs to develop in gestation. So the thing that gets very early babies, like 24 weeks, 26 weeks, is their lungs don't make surfactant yet. So they're born, and essentially they're not strong enough to inflate their own lungs because their lungs don't have this surfactant to make them nice and bubbly so that it's easy to inflate. Today, we actually have made surfactant in the laboratory, and we can swoosh it down into the lungs and put surfactant in from the outside. It has saved many a preterm baby's lives and many a drowning victim's lives, too. All right, so that's the story of the type 2 pneumocytes. Then the last cell I want to point out is these guys. The alveolar macrophages work like little robot vacuum cleaners. Okay, so we have this filtration system that we talked about the other day. Mucus captures particulates, captures dust, small debris, things like that. It isn't perfect. There is still some very, very small debris that makes it all the way down into the alveoli. And like I drew on the board, it would just fill up eventually, and we would die much sooner because our lungs would fail from all this dust and dirt in them. So the alveolar macrophages, they cruise around, gobble up any debris, and either destroy it or transport it to the capillaries for removal from the lungs. So it's a built-in sort of final stage cleaning system, these alveolar macrophages are. Okay, so close-up view of the alveoli. Now I want to bring your attention back to this spot right here. Okay, so capillary wall cell, type 1 pneumocyte, thin membrane in between. That is what we call the respiratory membrane. And it is across the respiratory membrane that oxygen and carbon dioxide move. So if you have a problem with the respiratory membrane, you're going to have a problem with oxygen getting into the blood and carbon dioxide getting out. So the whole respiratory system is really based on creating and keeping functional this very thin membrane between air and blood. All right, so what makes it up? Lining the inside of the alveoli is that surfactant I was just talking about. Underneath that, this is that type 1 pneumocyte, right? So that thin, flat cell that gives structure to the alveoli. Okay, that's these purple cells. Then we have a basement membrane. Remember, all epithelia sit on this sheet. Okay, in the lungs, the sheet is fused between the type 1 pneumocyte and the capillary wall cell. Okay, so we have this thin sheet, basal lamina, basal membrane. Here is our capillary endothelial cell, also a squamous epithelial cell, also very, very thin. So that's it. That's all that sits between air and blood. And you can see that the width of this structure is exceedingly small. Okay, so this is 0.5 micrometers. Teeny, 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 tiny. And the reason for that thinness is the thinner the barrier, the quicker oxygen and carbon dioxide can move down their diffusion gradients, which we'll talk about in a little bit. So like I say down here at the bottom, this really is the business end of the respiratory system, this respiratory membrane. And this is a very star-worthy, highlight-worthy slide, right? Because I can guarantee you, I will ask you, what makes up the respiratory membrane? Okay, so surfactant, type 1 pneumocyte, capillary endothelial cell, and the fused basal lamina in between, or the fused basal membrane. All right. Why make such a big deal about this? There is a list of lung syndromes that are the direct pathophysiology behind it is disruption of this respiratory membrane. So, for example, you all may have heard about what do they call it? SARS. Remember that severe acute respiratory syndrome people were getting some years back? Well, it caused ARDS, adult respiratory distress syndrome, which is a widening of the space between air and blood in the lungs. If you put fluid or inflammation here, then this distance gets further, and no matter how aggressively you push air into the patient, oxygen can't move into the blood, carbon dioxide can't move out. So you have a death spiral when the respiratory membrane starts to fail. And when you get to that point, it's very, very difficult to fix because the patient's lungs become non-functional. So you start, you can even go to the extremes of putting them on a heart-lung machine if you think that their lungs are going to get better at some point. So this respiratory membrane, when it goes bad, is one of the things that kills people. So that's why I make such a big deal about it now. And you'll learn lots of more things about it as you go on. Okay. All right, so that's the setup. That's the anatomy, right? So we've got an upper respiratory system that cleans and conditions the air. We've got a sort of middle respiratory tract, the larynx and the trachea that brings air from the head down into the chest. We get into the bronchial tree until eventually we get to the alveoli. And that's where the magic, or not the magic, but the business happens, where the molecules actually move, okay? So we have a couple of aspects of respiratory physiology I want you to be aware of. First, there's two different definitions for respiration, okay? All of you have had a cell biology class, and you probably all have heard this term. In the cell, if we're looking at the cell, respiration is this one. It's internal respiration. And that is the use of oxygen to produce carbon dioxide and fuel molecules. Okay, that's the Krebs cycle. You've all heard that before. When we talk about the human being, the organism, and we talk about respiration, we're talking about external respiration, which is all of the steps required to get oxygen into the cells and carbon dioxide out of the cells. So for my class, if you hear respiration, I'm talking about this, even though internal respiration is something that happens at the cellular level. Okay, so that's a gotcha, potential gotcha, external versus internal. Gas diffusion, also called gas exchange, is the movement of molecules. Okay, so we breathe air in and out. That is ventilation. Okay, ventilation is the movement of air. Diffusion is the movement of molecules, not the same thing. So what we're going to talk about here first is we move air in and out of the lungs. We're all familiar with that. And the reason we do that is to keep the air in the alveoli rich in oxygen and poor in carbon dioxide, so that diffusion can power the movement of those two molecules in their proper direction. So diffusion moves oxygen in to the blood, and diffusion moves carbon dioxide out. Neither of these can take place, though, unless we have adequate ventilation, unless we're moving air in a regular way. All right, so I say know all the bold terms. We're going to talk about many of these further as we go here. Okay, everybody loves slides that start with first some physics, right? Particularly those of you that have had a physics class in the past, but this is pretty easy physics. All right, just a reminder. You probably learned this in chemistry, really, okay? So it has to do with volume and pressure. So for a fixed amount of mass, in other words, for a fixed number of molecules, as the volume increases, in other words, if you put molecules in a bucket and you make the bucket bigger, the pressure inside the bucket goes down, right? So as volume goes up, pressure goes down. The opposite is also true. If we squeeze the bucket, the pressure in the bucket's going to go up, as long as we're not adding or taking away any molecules that are in there. Okay, so I point this out because essentially it is this property of the universe that our ventilation system, our air moving system, capitalizes on to actually get air to move. Okay, so our muscles increase the volume of the lungs. That causes a decrease in pressure, right? That's this line. That decrease in pressure then pulls air in to the lungs because the pressure on the inside of our chest becomes less than the pressure in the air around us, and air flows in. So just like we saw with blood pressure, things will flow from areas of high pressure to areas of low pressure. Okay, that's the other physics piece of this. All right, and you all probably learned it as Boyle's law. PV over T equals PV over T. I know you've done some problems with that in your high school chemistry classes. So, see, it does matter. It explains how our lungs work, too. Okay? All right, so that's how air moves in and out by changes in volume that result in changes in pressure. And I've got some better pictures of that as we go. But first, we have to talk a little bit about this strange evolutionary structure called the pleural cavity. Do you remember when we talked about the heart, how the heart lives in this little sac, right, so that it can move separately from its surroundings? We call it the pericardial sac. Well, the lungs have an almost identical covering system like that, where the lungs are not actually attached to the inside of the rib cage like you might think. Instead, just inside the ribs is this cavity called the pleural cavity. It's in white here. Do you see this little white space between purple lungs and white body wall? Well, that is the pleural cavity. And in the normal case, all that's in there is a thin amount of slippery fluid, just like we saw in the heart. And it evolved for the same reason. The lungs need to be able to move separately from the rib cage and body wall that surround them, because the lungs, they get bigger and they get smaller, and they have to slide as the rib cage expands and contracts. But what that means is it means that there isn't a direct connection between the ribs, which the muscles are going to move to create breathing, and the lungs themselves. But because this cavity is sealed, in other words, nothing can get in and nothing can come out, and because it's filled with fluid, not with a gas, as it maintains its pressure in the healthy state, which means that effectively the lungs are bound to the outside of the chest. They're bound to the chest wall, as long as the pleural cavity is intact. And when you get to a later class, you're going to see a whole variety of things that can really go strangely wrong when that isn't true. In other words, if you have a hole between your pleural cavity and the outside world, the whole respiratory dynamics, the whole mechanics of breathing breaks down. And essentially you can't inflate your lungs in that condition. But for our purposes today, we're going to assume that it's normal and healthy and that this is a sealed space, which means we can effectively ignore it. Because as the chest wall pulls on the pleural cavity pulls on the lungs, because there isn't anything else that can happen. Nothing can go in and nothing can come out. So it works as kind of glue between the body wall and the lungs themselves. All right, so same pattern as you saw in the heart, only for a different purpose. Okay, so how do we breathe anyway? We breathe using muscle to move bone. So just like we walk, how do we walk? Muscles pull on bones, changing the shape and angles, and propel us forward. Well, in the case of breathing, the bones being worked on are the bones of the rib cage. So you've all seen a skeleton. The upper half of the body has these sort of semicircular bones that come across. And what we don't always realize is they're not stationary. The ribs, where they attach to the spinal cord in the back, that's a swiveling joint. Okay, so the ribs can move. And the way they typically move is, if this is the ribs from the side, my thumbs are where they attach to the spinal cord. They stay in one place, but they rotate. Okay, so there's a rotation like this. So when you take a breath in, your ribs rotate up and out. So there's kind of, like you can see in this picture, we call that a bucket handle. If you've ever painted anything, you get a paint bucket, it's got a handle at the top, right? And it's got, 2 spots, and when you flip it, it goes up and out. Same idea. The handle is where it attaches to the spinal cord in the back. And we see this rotation motion of up and out. So we have 2 factors that change the size of the lungs. One is the ribs move, like you see here. The other is the diaphragm changes shape. Okay, so you remember the diaphragm sits at the bottom of the thorax, right? So, maybe I'll draw a bad person again, right? Lungs. Okay. So the diaphragm sits there in the bottom of the chest. And when we take a breath in, the diaphragm flattens. Okay, so it goes from dome-shaped to flat. And in our picture here, they're showing this to you from the side. Okay, so there's the dome, and then there's the flat. So, excuse me, I gotta take a drink. My voice is giving out today. All right. Two motions happen in the ribs, or in the chest. One is the floor goes down. So when the diaphragm contracts, the dome shape becomes flat, and essentially the bottom of the lungs is pulled down. Okay? So remember the volume pressure difference. You take the same amount of air and you increase its volume, you drive the pressure down, right? So if you think about this room, if somebody came and dropped the floor by 3 feet, the volume of air in the room would go up and the pressure would go down if the doors were sealed, right? So that's what's happening at the diaphragm. At the same time, in normal breathing, the ribs move up and out. So while the floor is dropping, the walls are going out. So we have the same thing. We have an increase of volume, which causes a decrease in pressure. So every time we inhale, the diaphragm flattens, the ribs come up and out, the volume of the lungs goes up, which means the pressure inside them goes down. Okay? That's the root of it. That's the basics of pulmonary mechanics. Is muscle increases the volume of the lungs, and then when those muscles stop contracting, the lungs recoil, go back to their original smaller size, and the opposite happens. Then the pressure goes up because the volume went down, right? Okay. So that's the basics of the mechanics. So up and out, down and flat. Okay. So what does that actually make happen? Okay, so this is an inhalation, right? The ribs have gone up and out. The diaphragm has flattened. So the walls got bigger and the floor got went down. That causes the volume of the lungs to go up. As the volume goes up, the pressure goes down. Now, we're surrounded by pressure all the time, right? The planet is pulling the atmosphere down towards itself because of gravity, so that creates a pressure. So when the pressure in the air around us becomes greater than the pressure in our chest, let me rephrase that. When the pressure in our chest becomes less than the pressure in the air around us, here we get air flowing in, air flowing from high pressure to lower pressure, right? So we get air movement coming in. Then when we exhale, the opposite happens. The lungs recoil. Lungs are like balloons. You know, when you blow up, you have to put pressure, you have to put energy in to blow up a balloon. But when you deflate a balloon, you just have to let the neck go, right? And it deflates itself. The lungs are just like that. They're elastic. So we have to put energy in to inflate them. But we don't have to put any energy in to deflate them. They deflate all by themselves. So here we have, the muscles stop contracting. The lungs recoil like a balloon. Their volume gets smaller, which causes the pressure to go up. When the pressure in the chest gets higher than the pressure outside, boom, air goes out. It flows down its pressure gradient from high to low. So we have an inhalation and an exhalation. And the key to both is this line right here. So why does air move in our respiratory system? Because of pressure differences. Where do those pressure differences come from? Changes in volume. So we breathe by changing the volume of our lungs to change the pressure inside them to get air to move in or out, depending on if it's inhalation or exhalation. And typically in quiet breathing, like you all are doing right now, inhalation requires energy because muscles have to pull the ribs up. The diaphragm muscle has to pull itself down. So you have to spend ATP to breathe in. But in quiet breathing, breathing out doesn't require any energy. Okay, the lungs recoil because of their evolved structure. So they snap back. You don't have to put any energy in there. All right. So this is another asterisk-worthy one, because this is the core of ventilation mechanics. How do we actually breathe? It's very different than a balloon. You know, when you go to blow up a balloon, you blow air into it, right? That isn't how our lungs work. If you took that balloon and you put it in a jar, right, and then you pulled air out from around that jar, from around the balloon, and the balloon would inflate from air pressure. Some of you will have seen this in a demonstration before, right? That's how our respiratory system works. Now, if a person on a ventilator works just like a balloon, we basically are blowing air into their lungs to inflate them. But that isn't how our system normally works. Normally, we inflate by decreasing the pressure around the lungs instead, just like blowing up a balloon inside a jar that way. Okay. So just to see that, if you're a graph person, this is the pressure, the difference in pressure between the air and the inside of the lungs. So as we inhale, that pressure difference becomes negative, so air flows in. As we exhale, that pressure difference becomes positive, and air flows out. All right. And what we see is this moving air causes this phenomenon called tidal volume. All right, so our lungs have a volume of air in them all the time, right? They're never deflated unless you're in the hospital with a life-threatening injury of some kind. But they always have air in them. So as we breathe in, the lungs get bigger. As we breathe out, the lungs get smaller. So the difference between breathing in volume and breathing out volume, we call that the tidal volume, or how much air did you actually move in a breath. Again, more on lung volumes in just a minute. All right, so inhalation, exhalation, and then tidal volume. So what are the muscles that do this? Yes? Yes?
Going back to like the pleural cavity, if somebody say
Here?
rib punctures their lung, that's a big deal.
In part because of pleural cavity problems.
Okay,
yes.
so when they refer to puncturing the lung, does that mean they're puncturing the pleural cavity, or are they actually?
No, a rib can actually puncture the lung. The lung is encased in a capsule, which isn't very durable. So, and ribs, as some of you will see in the cadaver at some point, are very sharp when they break. Very, very sharp. So literally it pops right through. And the problem there is now every time the patient takes a breath, some of that air leaks out into the pleural cavity. So they take a breath in, and some of that air doesn't stay in their lungs. It goes in the pleural cavity instead.
And then that would cause swelling in the pleural cavity?
Yes, the pleural cavity gets bigger and bigger, and the chest is surrounded by bone. So if the pleural cavity is getting bigger, the lung is getting smaller.
And then that would mess with the pressure and volume as well.
Correct. Yeah. So another example of pleural cavity trouble. You know, let's say you've been shot in the chest, right? So now you've got a hole between the outside world and your pleural cavity. Every time you take a breath in, your diaphragm pulls down, and instead of pulling air in through your airway, it pulls air in through your chest wound. We call that a sucking chest wound.
So you have to close it?
Yes, exactly. They have what's called an occlusive dressing. You know, like your battlefield medics have that, where it's airtight, and they slap it over there, and you have the patient breathe out, as take some big breaths out, and that usually gets the lung to inflate a little bit more. But ultimately, you've got to have it heal. Yeah. Yeah, pleural cavity stuff is very interesting, but we don't have time. Okay. So, the heart compared to the respiratory system is simple. You got one muscle doing all the job. Okay, you've got one muscle contracting. For the respiratory system, you're talking about moving a lot more stuff. You're talking about moving bone, you're talking about moving lung underneath. So there's a whole set of muscles that does these. This is also, and many of you will complain, an asterisk-worthy slide. I do want you to know the muscles of inspiration and expiration. Why? I always try to tell you why if there's a list, because everybody hates lists. You're going to assess these muscles when you're determining if a patient is in respiratory distress. In other words, is there something wrong with their respiratory system or their health otherwise that is causing them to breathe harder and faster than they should? And one of the ways of doing that is to look at the use of what we call the accessory muscles of respiration. Okay, so there are primaries and there are accessories. Primary inspiratory muscles, we're using those all the time to breathe. You know, whether we're exercising, sleeping, sitting, anytime. So every time we breathe in, we're using the diaphragm and the external intercostals. The external intercostals are pulling the ribs up. The diaphragm is flattening itself to pull the bottom of the lungs down. Now, the accessory muscles we only use if A, we're exercising. In other words, we need to increase the amount of air that we're moving in our system, or if the lungs or the respiratory system are struggling somehow to keep up with the body's needs. You know, so think in an asthma attack or in a bad pneumonia, then patients are going to be using their accessory respiratory muscles to move that rib cage even more to fight against the sick lungs. Okay, so the accessory inspiratory muscles all insert on the rib cage. So this is the sternocleidomastoid muscles, the scalene muscles that come in from behind, the pectoralis minor, which sits under the pectoralis major, and then the serratus anterior muscle, which sits sort of off to the side. All of these do the same thing as the external intercostals. They pull the ribs up and out. Okay, so it's extra help for these, because the external intercostals are really not very strong muscles. These guys are, particularly the sternocleidomastoid and the serratus anterior, are big burly muscles that can really move the rib cage around. The accessory expiratory muscles, we do use them in exercise, but where we're most conscious of using them is if we're breathing against resistance. Okay, so this is talking, singing, blowing up a balloon, playing a wind instrument, whistling. Anytime we're pushing air out, the lungs don't have a pushing mechanism. Sorry about that. I didn't silence my phone before I started. So muscles have to do that. And most of the muscles of accessory expiration are your abdominal muscles, right? So these should sound familiar. You've got your external obliques, the rectus abdominis, and the internal obliques, your abs, right? Well, how does that work? Well, when your abdominal muscles contract bilaterally, in other words, on both sides at the same time, they squeeze the contents of the abdomen. And because it's a sealed container, as the abdominal muscles squeeze the contents of your abdomen, they get pushed underneath the diaphragm. So, you know, the diaphragm's a dome, right? As the abdominal muscles contract, your liver, your stomach, and your small intestine get pushed up underneath the diaphragm and effectively work like bellows on the lungs. So the contents of your abdomen push up on the bottom of the diaphragm, and that pushes air out of the lungs, right? It's this push approach. The other two, the internal intercostals and the transverse thoracis, which sits underneath the ribs on the front side, they play less of a role, but they work opposite the external intercostals. So these top two squeeze the ribs together and squeeze the lungs from the outside. So the diaphragm pushes up from the bottom, that's the abdominal muscles, and then the internal intercostals and transverse thoracis squeeze the lungs from the outside. Typically in respiratory distress, you see these muscles are used first, and then in extreme respiratory distress is where you start to see these muscles being used. So like in asthmatics, for example, if you feel their abdomen and their abdomen is contracting every time they breathe, they are in significant respiratory distress and eventually are going to tire out and have respiratory failure. So they are important to muscles to know. All right. Okay. Time for this for sure. So one of the ways of looking at the lungs and their capabilities is to look at their volume. So, you know, we just were talking about the heart and how end diastolic volume is the largest the heart gets, end systolic volume is the smallest. So we're using volume to describe function, right? Fills, contracts. We're doing the same thing here. Okay, so graph, always look at the axes first. Over here, this is time, right? Because the lungs change according to what we're doing. This is total volume of the lungs. So if you were to, take a fancy X-ray and measure the total volume, the red line is the size of the lungs at a given time. All right? Okay, so you're breathing, like you're doing right now. You're breathing in, you're breathing out. You're breathing in, you're breathing out. Those are normal breaths, right? Kind of small compared to the whole size of the graph, but that's what we human beings do. We have a lot more respiratory capability than we need just sitting there doing nothing. Okay, so typically when we're at rest, we're breathing in about 500 cc's, we're breathing out about 500 cc's. That's what we call a tidal volume, the amount of air moved in a single normal breath, technically a resting tidal volume. Okay, but we of course can do more than that, right? So you're breathing along, and I say, okay, now breathe out as much air as you possibly can from your lungs. Put maximal effort into it, right? So you blow, 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 until you can't blow anymore. Well, as you're blowing air out, your lungs are getting smaller and smaller and smaller, right? Until they reach the point where they're smallest, that you can force them to be with your own muscle activity. We call that the expiratory reserve volume, is how much extra air you can blow out over where you sit and breathe normally. Okay, so we call that the ERV, expiratory reserve volume. Then you take that air back in and you breathe another breath. Now I say, okay, now take the biggest breath in you possibly can, right? So you breathe in and in and in and in and in and in. Your lungs get bigger and bigger and bigger and bigger until you feel like your chest is going to pop. At some point, you've gotten your lungs to be as big as you can make them. That is the inspiratory reserve volume, right? So the maximum volume that you can make your lungs under conscious effort, right? If we put those two things together, if I say, okay, you've taken this giant breath in, now blow out all the air that you possibly can out of your lungs. So now you're blowing, it gets smaller and smaller and smaller and smaller until you get back here to your expiratory reserve volume. That amount of air from biggest possible inhale to greatest possible exhale, we call that the vital capacity. And that is the maximum amount of air your lungs can move in a single breath. Okay? Now, this is remarkably stable over time. So yes, you can work out, and yes, you can train your respiratory system, but vital capacity doesn't change very much. And the reason for that is most of its size is determined by your bones, by how big your chest cavity is, right? So you can't change that with exercise. All right, so that's your vital capacity. And then you'll notice down here that the lungs never completely empty. In other words, they never get down to volume 0. It's because if they did, they would be very, very difficult to open. So one trick that has evolved is to keep some air in the lungs all the time. Because as long as there's some air in there, you don't have to put in the effort of opening all those alveoli. They're already all open. They're just not as big as they could be. Okay? So I'm hoping you're going to talk about these pulmonary volumes in lab. Have you done that already? No, hopefully you will do that. But I do want you to know these four. So the IRV, the ERV, the tidal volume, and the, well, not total lung capacity. It should be the vital capacity, VC. All right, but we're out of time, so I have to stop because I don't keep you late. Okay? So we'll pick up there tomorrow.